Dear colleagues, dear friends, it's a great pleasure to welcome you to this new EHAT podcast. Today we will focus on surgery in patients with hemophilia, but patients without inhibitors. So today I have the great pleasure to welcome two colleagues and friends, Maria Elisa Mancuso from Milan and Yesim Dargaud from Lyon. So, clearly, in a podcast, we cannot reflect the entire content of your nice presentation with great slides, but one of the key messages that you emphasized is that surgery in patients with hemophilia should be planned. This is very important. So this is not something, you decide on a day and you perform the day after. So maybe, could you elaborate a little bit on this key principles of planning?
Yes, Cedric, it comes together with the fact that we always say that hemophilia care needs a multidisciplinary approach. So a part of that is related also to surgery. So to have a successful surgery, first of all, we need to harmonize and organize the teamwork. And the team includes hematologists, includes the surgeon, of course, anesthesiologist, but includes also the pharmacist and the nurse, and then the rehabilitation team. Because if we think about orthopedic surgeon, which is one of the most common surgery performed in hemophilia patients, we have to take into account everything since the beginning. At the beginning is like we shouldn't be fully aware of the type of surgery we are doing and the bleeding risk associated, and then who is the patient receiving this surgery in terms of diagnosis, but also maybe some complication around the disease, so having or not having an inhibitor, even in their history, how he's performing with the response to the drug, and then having all available. I mean, a good surgeon able to do this surgery, and anesthesiologist who follows our advices in terms of increasing or decreasing the bleeding risk, and should be also aware how important it is to follow the scheme of treatment to maintain a good hemostasis. And then we need to have the drug. So we should have an adequate amount of drug to cover not only the surgical procedure per se, but also all the post-operative period, because we know we should cover at least until wound healing. But especially for orthopedic surgery, then we have to think about the rehabilitation post-surgery. So then we have to have on board nurses, physiotherapists, and all the rehabilitation team, who also should recognize the importance to continue the hemostatic treatment. So we should have, again, the pharmacist on board to provide in adequate amount also to cover that. So, everything can be planned upfront, and for sure, planning and organization are key to a successful surgery.
Even the date of the surgery should be planned, because I wouldn't make a major surgery in a severe patient a Friday or Thursday, as we need to follow up them. So
I agree with you. So clearly, we should have our checklist ready and make sure, as you emphasized in the webinar, that everything has been checked, everything is in place, and there is no bad surprise on that day. So maybe, Yesim, maybe you could share with us what would be the key principles, the key modalities of hemostatic therapies at time of surgery. We will cover later on emicizumab, but how do we use clotting factor concentrate?
Well, I think we should take into account not only the properties, the characteristics of the factor concentrates that we use, but also the patient characteristic and this individual PK values, because to reach the target factor VIII levels that we would like to have for surgery, we need to know the individual recovery of the patient. So we have to calculate it, whatever the severity of hemophilia, we would like to be in the safe range as indicated with the WFH guidelines.
And in terms of levels, so levels that we need to achieve and duration, concisely, what would be your key recommendation?
Well, I think in France, or if we have access easily to products for major surgery, we would be at between 80-100% of factor VIII for major surgeries and above 50 for minor surgeries.
And for how long that depends also on the type of surgery.
Depends, of course, for the rehabilitation or not, but for major orthopedic surgeries with rehabilitation, we usually cover for 3 weeks our patients. And for, major surgery without rehabilitation, it depends between 7 to 10 days. And in minor surgeries, some days, 2 days, 3 days are sufficient. But it depends, again, what's the level of the patient, if it's a mild hemophilia or severe. So we will discuss individually.
And I think what we need to do is to visit these patients every day and make sure that provide advice as an hematologist.
Again, Federica, I think also here the multidisciplinary team comes, because sometimes the surgeon can also advise us to cover much or less or longer, considering also how the wound is evolving, because sometimes there are some local issues, and maybe you will see that if you continue to cover and provide a good hemostasis, we know that this impinge upon also wound healing. It's not just a matter not to have a bleeding complication, but also to favor wound healing. So sometimes also having a good conversation when they are doing their check on the wound and so on can be also a good way to plan the treatment.
Yeah, I think this is important. We should be very close to the whole team after surgery. So maybe let's move on now to a very important treatment option, which is emicizumab, increasingly used. So that means that we have now more and more patients on emicizumab who undergo surgery, minor, major. So maybe, Maria Elisa, could you explain, because for some of the colleagues it's a bit difficult to understand how emicizumab and factor VIII do interact. So is there a additive synergistic effect? How do they work together?
Yeah, emicizumab is a monoclonal bispecific antibody mimicking the cofactorial function of activated factor VIII, meaning that it acts bridging factor IX to factor X. But it's a monoclonal antibody, and by its nature, its affinity to such a substrate is much lower than the natural affinity of factor VIII. So I would say that there is no interaction between the two, meaning that as soon as factor VIII is present, it displaces completely at let's say, a therapeutic doses that we use usually. It displaces completely emicizumab from the substrate, which is good because we can control for the effects of this drug. And also not having interaction, these also minimize the thrombotic risk because we have no additive effect. So in a way, in non-inhibitor patients, this is a good way of interaction because there is no synergistic interaction.
And which patient should be given adjunctive or additional factor VIII for surgery when they are on EMI? What sort of procedure would you advise to give concomitant factor VIII?
But I would say that looking at the hemostatic potential, as far as we know from EMI, it is not completely normalizing the coagulation activation. So for major surgery, it's needed still to go for supplementations or replacements. We have knowledge from the real-world experience and the clinical trial that some minor procedure can be performed without adding factor VIII. In some cases, especially dental procedure, though, we still need some antifibrinolytic agents because of the local nature of the activation of coagulation. So I would say that for major procedure, for sure, taking into account that we can safely use the standard doses of factor VIII to replace these patients.
And Yesim, since you have a major lab interest, so what sort of assays do we need there when a patient is on EMI, undergoes major surgery, you give him factor VIII? So what's very important to have in terms of blood test?
Well, for factor VIII replacement therapy, we need chromogenic assay with bovine reagents. And if I project myself in few years later, and we will have ultra extended factor VIII molecules, for which we need one stage assay, it will be a bit more complicated. We need to have new assays to monitor the combination of emicizumab with EFA. So this is a challenging point. But for today, the question is easy. Bovine chromogenic would be enough.
But again, that's emphasize the importance of this teamwork, because the lab needs to know that that surgery will take place and that all the reagents, everything should be in place. So if you had, because you have a major experience in this field, so have you had problems, when managing surgery in patients on emicizumab, in your own experience, rather positive, negative?
As far as I can remember up to today, I had always successful outcomes. It was, of course, very important to have a lab supporting me and giving me timely the result of the levels of factor VIII. So I was somehow reassured, not only by the clinical situation, but also from the lab, that what I was giving to patients. And I have some also experience of minor surgery or dental procedure done only with tranexamic acid, and maybe just one preoperative, let's define it like that, little amount of factor VIII, but then nothing afterwards. So also in my, let's say, clinical experience, this reflects what we learned from the clinical study.
May I add something? As we do not know exactly what's the hemostatic level of the patients, in my center, we are playing the safe, side of the coin. And for any major surgery, as we do not know if the patient has a sufficient hemostatic level or not, we give factor VIII concentrates on the top of emicizumab. But there is something that we didn't discuss yet. This is the emergency surgery. And it's really mandatory that these patients have an emergency card indicating that they are on EMI, because otherwise in the emergency wards, they can have just an APTT showing that it's normal, and then they can wrongly go to the surgery without any replacement therapy. So we should avoid this for any price. They all need to have a card on them.
Well, colleagues who are less familiar should not be misled by normal APTT in this patient. So, and I think we also need to tell our patient if they have an accident or trauma, they need factor VIII. They still have hemophilia. This drug is great, but they still have hemophilia. Yeah, and maybe in my experience also, what's great with EMI is that the rehabilitation phase is facilitated by this. And sometimes patients can be discharged earlier than before because they have good levels. Well, they might need a little bit of factor VIII on top before some very active physio session at the beginning, but I think it does facilitate the rehabilitation. You agree with me?
Yes, I fully agree. And also by experience, I can tell you that if I compare my experience with the pre-emicizumab situation, for sure, I think that we do need factor VIII replacement until wound healing, complete wound healing, maybe at a lower doses and maybe longer intervals. But after that, when the patient already started rehabilitation, so he's already somehow a little bit trained, he can continue rehab on EMI without the need for factor VIII. This is by experience.
Maybe, we are close to the end now, but maybe you could comment quickly, because a new ultra-long or high-sustained factor VIII activity should be increasingly available. So how will be the impact of that drug on surgery? Very positive, I assume.
Probably it will make life easier, and we will not have to monitor patients from the laboratory, every day. Probably we can get laboratory feedback every 2 or 3 days, but we will learn about with our own experience. But this is the information coming from the studies. And probably the hospitalization length duration will be shorter with this drug. So we have 2 doses. We do not have to go higher than 50, and for the second dose higher than 30. So the PK looks very stable. So I think this will make life easier for us and more safe for our patients.
And also for the team, if I think about nurses in the ward, we sometimes we struggle because we have to remind to give the dose at a certain time because it's important. But then if the PK is so stable, we can also relieve somehow the nurses from, that, and just say, okay, you do just this dose at that time, and that's it. So maybe this is also another advantage.
Well, we won't have time today, but I think in the future there should be a specific session focused on surgery in patients with rebalancing agents. It's a bit complex today, and also in patients who had gene therapy. I think that very nice data have recently been collected. They should be available in the near future, and I think we'll have to discuss this. But for the sake of time, it will be difficult to do that today. So, well, I think we are really close to the end. It was very nice to have the two of you. It was a very nice interaction in this field, also in this friendly atmosphere of the EHAT podcast. So Maria Elisa and Yesim, I would like to thank you again for preparing these great webinars that I invite you, our audience, to watch. And thank you for your time and for making this possible, and hope to see you soon.